Can you guys watch the videos at all? Anybody watch them? How's the audio? Is it okay?
It's okay, but it's just because I also go on Zoom sometimes.
Yeah.
So it gets a little staticky and slow, and then it cuts you out a little. Also, it's reversed. It's like flipped. Do you see yourself on there? You're like on one side of the screen, and then you're on the other side.
Oh.
Okay. So like whenever you share your screen, it's like whatever, right? But like when you only just like have yourself on there, then it's like we have to like pull up our PowerPoint stuff, right? You can't read that.
Wait, so this is flipped.
Yeah, your whole screen is flipped. You can look at it. Look
Okay. All right, people on Zoom, like this is, we gotta, hold on.
The audio is okay for majority.
Zoom recording. Okay. Y'all have to tell me these things. I can't fix things if I don't know what's going on. How often do you think I look at myself in the corner? Just so y'all know, I've never watched myself on video. I've never listened to myself. It terrifies me and causes me so much anxiety to even think that you guys listen to me, right? We all have verbal tics. We all have hand tics in various things. And I don't want to know what mine are. I don't want to know about it. It makes me so incredibly anxious to think about those kinds of things.
You sound fine on there. It actually sounds a lot better than you think with your microphone being so far away.
Okay, well, part of the reason that I ask is I have a thing that they gave us last year that looks like a flying saucer pod or something, that is a big microphone that is meant to be set like in the middle of the room, and it's meant to be super sensitive to like capture discussion audio and things. And I was just wanted to know if I needed to try to bring it in, and I had forgotten about it, and I'd stuck it in a corner, and I found it last week cleaning my office. I'm just going to see if we should bring it in and try that, if that would make the audio.
The discussion on here is like the only thing you take from us.
Okay.
We can only review.
Okay. Good to know. Good to know. So this stuff won't be on the test. Nobody freak out. There's not the study guide for test 2, so the study guide to follow along if you take notes in the study guide for things, it's not up for this yet either. I just ran out of time this morning. So our next thing that we're going to do is we're going to move from talking about muscles and resistance training and things into talking about the cardiorespiratory system. Okay, so heart, lungs, okay, blood vessels, and all of the kind of integrated functions that are going to be encompassed there. Okay, so we will start off talking about the cardiovascular system, and we're going to do this very much like what we did with muscles, that there will be some basic anatomy and physiology of the cardiovascular system, some basic anatomy and physiology of the respiratory or the pulmonary system, okay, lungs and how those things work. Then we will talk about what happens when you exercise or engage in physical activity. Okay, what is it that changes? Normal function looks like this. When I exercise, this is what happens. Okay? So we probably won't get to some of that stuff until like Wednesday, probably Monday of next week, Wednesday of next week. All right. So the cardiovascular system obviously is very, very important. Okay. Having normal function in this system is really important. And its real function, I think, is to support other physiological systems. It supports metabolism. It supports muscle function. It supports nervous system or brain function. Okay. This is also the system where we tend to see a lot of the pathologies that are associated with obesity and sedentary behavior. So when the cardiovascular system doesn't work right, it causes lots of problems in our other systems. Okay? So it plays a huge role in our ability to exercise and controlling, especially endurance exercise performance. And therefore, it plays a huge role in activities of daily living, especially in older people. Okay? If your cardiorespiratory system doesn't work properly, okay, then we're going to have all kinds of problems. Your cardiorespiratory system doesn't work properly, you're at what, like 10 times the risk of dying of COVID or something now as well. So just keep all of that in mind. The really good thing is that even though it's very, very susceptible to pathologies, is that it's also going to be really, really responsive to increased physical activity and to exercise training, which is good because if you get people that have problems, if you'll get them to be more active, it can counteract a lot of those potential pathologies. So there's a big, big chance for using exercise as a treatment in the cardiorespiratory system. Okay. All right. So you guys don't have to memorize all of these things here on the function of the cardiovascular system, but I want to give you a little flavor of the things that it does. One of its primary roles that we're going to focus on is going to be delivery. Because when we say delivery, we're talking about oxygen and nutrients, glucose or some kind of carbohydrate that we're going to use for energy, okay? Or lipids, fat, it's going to be used for energy. So think of it in this way, that the cardiovascular system functions very much like the Amazon delivery guys or girls, okay? So it's going to move things around. It's going to bring it to you. We all want it to be next day, overnighted, right, and to not cost us anything. If we do all of that, some of its other big functions are going to be removal. We're going to talk about how it gets rid of carbon dioxide that is made as a consequence of aerobic metabolism and kind of the role of that carbon dioxide in regulating pulmonary function. Other waste products that we're not really going to talk about in this particular class. But things like lactate or hydrogen ions, which lactate is really not a waste product, but lots of times people think of it that way. Metabolic byproducts and things that need to get kind of moved out of muscles. It transports hormones, right? A lot of endocrine function. Obviously, to be endocrine function, it has to come out of one tissue, go into the bloodstream, and get taken to another. So we deliver hormones and neurotransmitters all around the body using the cardiovascular system. It plays a big role in maintaining body temperature. We'll speak about this just a little bit, as well as the cardiovascular system and the pulmonary system help us regulate pH, pH balance, maintain homeostasis there. And then it has a very, very large role in immune function, in preventing diseases, in sort of causing inflammation to allow us to heal and those kinds of things. So all of this, you can see, right, we've got overlap between a whole host of other body systems that are going to be encompassed in all of this. Okay? In the cardiovascular system, we're going to talk about three primary structures. There are more structures than this, but there's three primary groups that I'm going to put things in. And we'll take each of those in turn and dig in a little bit on their anatomy and the physiology that lets them function in a proper way. So we'll talk about the heart, okay? We'll talk about blood vessels, different kinds of blood vessels, and then we'll talk about blood, which in some ways to me is maybe the most underappreciated, if you want to call it a tissue in the body. It has really, really important functions that are essential for life. And we don't talk about it very much, I feel. Okay, so we're going to talk about all of these three things and kind of how they work together and fit together. All right, here is a heart. No one freak out. No one have flashbacks to anatomy. Okay, nobody do that. We're going to be okay. We're going to get through this together. All right, everybody, take your left hand and stick your left hand out in front of you and make a fist. Okay, I want you to have sort of where your index finger curls around like this at about a 45-degree angle to the ceiling. Okay, this one at about a 45-degree angle up from your hip. So we're going to do this. Now take your fist and put it just ever so slightly to the left of center in your chest, right here. Okay, that's your heart. That's its orientation relative to everything else. That's approximately its size. Okay, in most people, it's about the size of your fist, and it sits right about here, slightly left of center, and it's going to be oriented like so. Ta-da! There is your heart. Remember, we're looking into the chest on all of this, so everything is flipped around. This is the left side of what appears to be your right. This is the right side of what appears to be your left. Okay. All I want you guys to know, all I want you to know are the four chambers, the major blood vessels, superior vena cava, pulmonary arteries, pulmonary veins, aorta. That's it. Those are the 4 things, 8 things that I want you to know from an anatomy standpoint. I also want you to know the pattern or movement of blood, the pattern of blood moving through those 4 chambers. Okay? That's it. You don't have to know about the valves. You don't have to know, right, how many flaps the valves have. You don't have to know about chordae tendineus, know about any other things. I'm not going to talk about, you have to know coronary arteries or anything at all. That's all I want you to know. Okay? Can y'all handle that? Yes? Okay. So, I know there's more on this particular thing than what is there, but I just want you to know this. Okay? So, venous blood returns to the heart through the superior vena cava. That blood moves into the right atrium. It then goes to the left atrium. I'm sorry, not the right atrium, the right ventricle. Okay. It then goes out through the pulmonary arteries to the lungs, where it picks up oxygen. It then returns through the pulmonary veins, returns into the left atria, and then moves into the left ventricle where it is ejected out through the aorta. Okay? That's all I want you to know. If you know that much, we're going to be able to understand what happens with exercise. We're going to be able to understand what changes with exercise, and we're going to have enough of an appreciation of the differences in oxygen concentration in each of those places to be able to kind of have a good handle on things. Okay? That's it. That's all you got to know. All we got to know. Okay? Okay. So let's talk about the heart in a little bit more depth. Okay? The heart is a muscle. It's just one big muscle. We call cardiac muscle the myocardium. Okay? The myocardium. It looks like skeletal muscle in that it has striated or sort of lined up sarcomeres with actin and myosin. So it looks under a microscope, it looks striped just like skeletal muscle. Okay? It also only has a few central nuclei. It has mostly peripheral nuclei, just like skeletal muscle. Things that make it different than skeletal muscle are these 2 things, okay? Plus some special structure. It has a very, 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 very extensive capillary network. Way more capillaries on the myocardium than on skeletal muscle. I don't care how trained your skeletal muscle is. Okay? The best marathon runner in the world, Eliud Kipchoge, does not have anywhere near as many capillaries in his leg muscles than what your heart does. Very extensive capillary network that is coupled with a huge amount of mitochondria. Okay? Cardiac muscle has about 40% of its cytoplasmic volume is mitochondria. Conversely, skeletal muscle is, in a really trained person, is maybe 5 or 6%. Okay? So I have lots of capillaries and I have lots of mitochondria. What does that left cardiac muscle do that skeletal muscle can't, or sometimes doesn't? Guesses? Yes, it does lots of contractions. That's right. What is made in mitochondria? ATP. Okay. What do I need to make the ATP in those mitochondria? Oxygen. Where might that oxygen come from? Capillaries? By chance. Okay. We'll get into the movements of sort of gases from capillaries and capillary exchange in a few slides. But together, we have a large ability to bring oxygenated blood in close contact with the heart and a tremendous ability to extract oxygen into those muscles, that cardiac muscle, and make ATP with it. Okay. Looking, he's got watch. Let's see. Okay. Ken, I'm going to go with you just because I see you have an Apple Watch. I should have worn mine. Can you look up what your resting heart rate is on there for us? See what we can measure heart rate to by just me talking to her.
I've never used that, not even gonna lie.
Okay.
So, oh wait, I think I see it.
61. Okay. According to this, McKenna has a resting heart rate of 61 beats per minute. Let's do some fun math. McKenna, would you mind telling us how old you are?
Yes, 21.
21. Okay. Like 21 and like a month or 2 months or
Like 6 months.
like 6 months. Okay. So we're going to take 21 years old. We're going to multiply that by 6. Can somebody do that for me? We're going to get the number of 6. God bless. I'm having a day. By 12. Sorry, 252. Plus 6, so we're at 258 months. Okay. Now we're going to do something really easy again. We've got that number of months. Let's multiply that by 30 for how many days we have. Somebody do that math for me. Sorry, 77. Okay, so we've got that number of days, right? Now let's take that number and multiply that by 24. We're going to get our hours in a day. Let's see where I'm going.
185,760.
185,760. Those are hours. Now multiply that number by 60.
11,125,600.
Okay, 11,145,600. 600. We've now just done a song from Rent, right? You guys know that? You guys know the thing Rent? No? Okay. Never mind, I'm aging myself. Okay. So we've got this number of minutes. Now multiply that by 61 beats per minute. Yes, it is a lot. I have a point to all of this, I promise. 679,
881,
881,
600.
600. Okay, so assuming that McKenna had that same resting heart rate and her heart rate never changed throughout her entire life, you should probably add like another 7 months onto all of that because your heart was beating when you were a fetus at a certain point. But roughly, her heart she's got 600, let's call it 680 million times your heart has contracted since you've been alive. Plus, we'll add a few more in there. Okay? 680 million. Has your heart ever been tired, McKenna? Like literally tired, not you're just like, oh, my heart hurts. This is not good. Right? Yeah, that's a psychological thing, right? Okay. Do you think if you had contracted your bicep, you'd done 680 million bicep curls, your arm would have been tired? Yeah? Okay, maybe. Also, it would be like the side you look like reverse like Popeye rather than having here, which would be like this giant thing. Okay. So 680 million. And I assure you it's more than that because it's never just been 61 beats per minute. Okay. Why is that the case? This. Okay. Lots of mitochondria, lots of capillaries. Okay. the next few slides, the thing that's going to blow your mind is that she's never once thought about having to cause any of those 680 million contractions to happen. You guys ever think about making your heart contract? You don't have to. It just happens. It's crazy. Okay. All right. So my silly math aside, I hope that illustrates the point of kind of what's going on with all of this. Cardiac muscle also has some very special structures that help ensure the way that it contracts, which is a little bit different than skeletal muscle. It has these things called desmosomes, which are going to occur kind of at the end of each of the muscle fibers that help hold our cells together. It has a thing called a gap junction, which is basically just a hole or a tunnel that allows for much more rapid action potential transmission, which will become very important in the next few slides as you see how we lack some level of nervous system innervation in the cardiac muscle. These two things together, the area where one cell connects to the next is called an intercalated disc, and that's just kind of what those special structures are. So here you can see one. These are individual cardiac fibers that are going to be here. See how they're nice and striated. You can see the nuclei. But at this area here, where one makes contact with the next, that's the intercalated disc. The desmosomes exist there and sort of clamp onto each other and hold us together. And then there's going to be these gap junctions that will allow for easy passage of ions. Okay. Okay. So hopefully I've illustrated to you guys that it's a little different than skeletal muscle. It has this tremendous capacity to aerobically generate ATP. Therefore, it can contract over and over and over and over and over again without it ever getting tired or without it ever getting fatigued. Okay. The next thing to understand, though, is that the way that we tell your heart to contract is different than the way that we tell skeletal muscles to contract. And again, this is structure imparts function. Okay? Structure imparts function. We're going to get in heart tissue, in cardiac muscle, an all or nothing contraction response, very much like in skeletal muscle. Okay? But in skeletal muscle, the all or nothing is one fiber is going to get a signal, and that fiber will contract, or all of a motor unit will contract. In the heart, what should happen is if any cardiac fiber gets a signal to contract, all of the rest of them should also get a signal to contract. So you should get the entirety of the heart to contract, or you'll get none of it. Okay? Now, that's not always true. It's not always true, but when it's not true, we've got real problems. Okay? We've got real problems. We'll talk about some of those in cardiovascular disease. Okay? The other cool thing about cardiac muscle is it has something called intrinsic rhythmicity. Intrinsic rhythmicity. Okay? Now, in some ways, this is not the way that we think of rhythm. You think of rhythm like can people sort of, can they dance, can you hear the beat in music? Hopefully some of you guys can. I cannot. My wife makes fun of me all the time because we try to do things and do little dances for our daughter to her Disney songs, and I'm always on beat. What it means in this instance is that cardiac rhythm is the frequency with which you're going to get action potentials and depolarization, and therefore a contraction of the heart. And so intrinsic means these cells will generate their own action potentials and cause a contraction all by themselves. Okay? Cardiac muscle has something that they're called leaky sodium channels. And what it means is that slowly we're letting sodium come in, and so we're going to slowly depolarize. And I say slow, it's actually very fast in comparison. Some things, but that's what we're going to get. So you don't have to have an external signal or an external stimulus. Okay? Now, there's leaky sodium channels, but there's also going to be something called the cardiac conduction system, where we're going to get some additional input from the parasympathetic and the sympathetic nervous system to help us have things contract. Okay? But the key thing about the cardiovascular system and the cardiac conduction system is there's no voluntary control whatsoever. You do not have control over your heart rate. You do not have control over when or how frequently your heart is going to contract. Okay? It's all because of the way this is going to go. We call this intrinsic rhythmicity autoconduction. It's kind of all going to be kind of in the same deal there. Okay? With no external input from the parasympathetic or the sympathetic nervous system, most people are going to have some sort of inherent rhythmicity that's going to equate to between about 70 and 75 contractions per minute. Okay? So you guys can note from all of that, that if McKenna's heart rate, her resting heart rate was 61 beats per minute, we're obviously applying something to this to slow down this inherent rhythmicity. Okay? If I wanted to, I could do fun things like ask Nikki to stand up on the desk. She's ignoring me. I could ask Nikki to stand up on the desk and sing us a song. I don't know. Do you want to? You could? Then you're way too into this. You're defeating my purpose. But right? I want the person that I'm just taking a shot. And you're like, okay, who do we think would not want to get up and have to do some sort of performance thing for the class? Okay? But I make you think about all of that and you raise your heart rate. I evoke a stress response. Release epinephrine or norepinephrine. We can make this beats per minute actually. So we'll talk about that. Probably not today, but probably on Monday of next week. We'll talk about how we're going to use acetylcholine and epinephrine and norepinephrine to alter sort of our contractions. Okay, so that's what's going to happen. So I want you to know the components of the cardiac conduction system. So these are going to be the structures that we're going to use to transmit action potentials through the heart to get the sort of atrial and ventricular rhythm that we need to be able to move blood around properly. Okay? I'm sure you guys have seen all of these before, right? But the original action potential that initiates the contraction in the heart most often comes from something called the sinoatrial or the SA node. Okay? It's located in the top of the right atrium here. And the SA node is just a collection of nerve fibers. Okay? It is sometimes called the heart's pacemaker. This is the place where we should initiate contraction. And most of the time, if you don't have some sort of pathology, this is where it's going to come from. Okay? The SA node is particularly sensitive to parasympathetic and sympathetic nervous system influence. Okay? All right. You may sometimes, depending upon what class you take or how you guys talk about these things, you may look at, say, an EKG response that we'll see in the next couple of slides, and people will talk about something called normal sinus rhythm. And what they mean is, what is the normal heart rate that is controlled by the SA node? That's normal kind of resting sinus rhythm is going to come from here. Okay? Now, the SA node depolarizes. It's going to send a signal down through the atria, okay, to the AV node, the atrioventricular node. As it moves, it's going to cause depolarization in this atria. It's going to cross over because we can transmit action potentials from one cardiac cell to the next, okay? Like skeletal muscle, each individual cardiac muscle fiber is excitable. It's going to get transferred over into the left atrium, okay? So we're going to move, we're going to get to the AV node, and the AV node is going to be our location here at this kind of wall between the right atria and the right ventricle. That's going to help us move our contraction from the atria down to the ventricles. Remember back from anatomy or remember from physiology that we get this sort of two-component contraction of the four valves or the four chambers of the heart, where the atria go first and they contract and they shoot the blood then into the ventricles, and then they relax and the ventricles contract. Okay, so when you listen to a heartbeat, like with a stethoscope, you hear both of these things happening. Okay, you can hear the contraction of the atria first, and then the contraction of the ventricles second. So the AV node is going to transmit the signal. I want you guys to note this down some nerve fibers that run down the septum here that runs in the middle of the heart. These are called the AV bundle or the bundle of His. Why His is spelled S-I-H-I-S, I don't know, but there we go. These nerve fibers allow us to transmit the signal faster than it could if it just spread across only the individual cardiac muscle fibers. That will become important in just a second. It comes down here, it reaches the bottom or the apex of the heart. These things then turn back up, okay? As they turn up, they're going to begin to branch off and become very, very highly branched. Those little branches are called Purkinje fibers. And the Purkinje fibers, in essence, wrap themselves all around the ventricles, okay? And so what happens is that these nerve tissues provide for very, very fast transmission, faster than we would get across the surface of the fibers. And so what happens is you get this contraction, okay? Blood comes in, you get the contraction of the atria, that sends blood off, sort of down into the ventricles. It's in the ventricles, but when blood needs to leave the ventricles, it has to leave out of the top, okay? Pulmonary arteries in the aorta are on the top side of the ventricles. And so what happens is we spread it down and we initiate the contraction of the heart from the bottom up. And it functions like when you wring water out of a wet towel, right? Start at the top and you squeeze, and you wring the toothpaste out of your toothpaste tube. Starts at the bottom and it squeezes itself up, and then that leads to blood gets ejected out of the aorta from the left ventricle and out into the pulmonary arteries from the right ventricle. Okay? Again, structure imparts function. Okay? That's the advantage of having the bundle of His and these Purkinje fibers. We don't have to have them. We could spread the contraction just across the cardiac. But if the top part of the ventricles contract first, because it's going to get here and then move down, but the blood has to leave out of the top, nothing happens. We're shooting the blood down and it gets all weird. Okay? So doing it this way, again, lets us move the blood in the direction that we're supposed to. All right. I mentioned this in the previous slide, that each chamber of the heart is going to contract and relax one time during one heartbeat. Okay? We denote the contraction and relaxation of each individual chamber as a period of systole, which is contraction, and diastole, which is relaxation. Okay? Systole and diastole. During diastole, when that chamber is relaxed, blood will be able to flow in, and that chamber will fill up. Okay? We'll get to this a little bit later on, but blood moves in your body via differences in pressure. It moves via differences in pressure. So when the chamber is relaxed, pressure in that chamber is very low. It's lower than whatever the immediately sort of proximal structure is. Therefore, it will try to send the blood from that proximal structure into that chamber. Okay? So in the atria, you've got, during diastole, pressures that are lower than what's either in the superior vena cava or the pulmonary veins. So the blood's going to move down its pressure gradient into those. Okay? Then the atria undergo what we call systole. They're going to contract. When you contract something, okay, when you contract something, it squeezes, it decreases the volume inside. As that volume decreases, the pressure on that fluid goes up. So atria contract, pressure goes up. Ventricles are now in diastole, they're relaxed, so their pressure falls. Blood then wants to move from high pressure to low pressure. It moves from the atria into the ventricle. Okay? Then the ventricles contract and they raise their pressure. When ventricular pressure overcomes aortic pressure or pulmonary arterial pressure, then the blood moves in that direction. Okay? Does that make sense? You guys understand kind of how all of that goes? And so every chamber in the heart undergoes its own period of systole and diastole. It's very orderly fashion during one single heartbeat. Okay? When we get to blood pressure, which we may today, people talk about measuring blood pressure as two numbers. One is called systolic pressure, the other one is diastolic pressure. What we're measuring basically is the pressure in a peripheral artery, I would say an arterial, but in a peripheral artery, like in the brachial artery, during contraction or systole of the left ventricle or diastole of the left ventricle, all the chambers of the heart. Okay. At rest, about 60% of a cardiac cycle is each chamber is spent in diastole, and about 40% is spent in systole. So you've got longer, okay, you've got a longer period of time to fill than you do to contract. If a cardiac cycle takes about 0.8 of a second at resting heart rate, then you can work all of those things out. Okay, you're spending just about half a second in systole or in diastole, and a little bit less in systole. Okay, those numbers are important. Will become important next week. Because when you exercise, when you increase your heart rate, then this amount of time, it doesn't take 0.8 of a second to do a cardiac cycle or a heart rate. It may take half a second, or it may take 0.4 of a second. And so what happens is as heart rate goes up, the amount of time, absolute amount of time we can spend in diastole is going to go down. And at some point, that becomes a problem for getting blood, especially into the left ventricle, which can limit some of our stuff. We'll do some more math on that. Okay. Okay. Now, you guys have seen an EKG before? You guys do EKGs in phys, in human phys? Yes. You know what I'm saying? Yes. The rest of you, do you remember? Put electrodes around your heart. If you've not done one, take exercise testing and prescription with Dr. Larson or Dr. Kellogg, and you guys will do these, okay? So what happens is we put the electrodes on, depending upon how many they want to put on. The traditional way to do this is to attach to what's called a 12-lead EKG. They put 12 electrodes on you. They go all around your heart. They put some here. They put a couple on your back. And what they're doing with those electrodes is they're measuring the electrical activity. They're measuring the movement of action potentials in the heart. Okay? So it's called an electrocardiogram. And it looks like this. Okay, this is a normal, healthy kind of EKG or ECG. And what you will note is you have these very distinct deflections in the electrical signal that are going to denote certain events happening in the heart. You get, when the atria depolarized, we've begun a contraction. Atria depolarized, that results in something called a P wave. When that is moved into the ventricles, you get this very sharp upward deflection because there's much more tissue there. You get this sharp deflection called a QRS complex. All right. We oftentimes talk about that the R wave denotes ventricular contraction. The R wave denotes that we move blood out of the heart, followed then by a deflection from repolarization of the ventricles, just like skeletal muscle, just like the nervous system. When these things get an action potential and they fire, they have to repolarize. We've got to run sodium and potassium pumps. We've got to move all of those ions back around. So we see this change in membrane potential, which is called a T wave. Okay? We don't see repolarization of the atria because it's hidden under or sort of in with the QRS complex. And when people have problems in cardiac conduction, very often due to a lack of blood flow to the heart, we can diagnose it by looking at this segment right here from S to T, this S to T segment. Okay? you can see some very distinct changes that are going to take place here that may tell us you've got cardiovascular disease. So this is normal. If you take exercise testing prescription, you guys will do some of these that look abnormal. So we can use this to denote, like, let's say your AV node isn't working properly, you may get a P wave and you're not going to get a QRS because it can't get through the AV node. That would look a certain way, okay? Or you've got some other problems. This is what this is going to be. I want you guys to know just kind of what each of these things look like to be able to draw this and tell me what happens in each individual spot. Okay, we won't do any pathological EKGs. I'm not going to give you anything and say, hey, tell me what you think is wrong or what's going on in the midst of all of that. I just want you to know the basics because we'll talk about them a little more when we get into cardiovascular disease. Okay. All right. When they think someone has had a heart attack, you go to the hospital, they put the electrodes on, they measure this, and they put you on the treadmill and make you walk. Or when they do a stress test, this is what they're doing. Okay. Seeing abnormalities on the EKG or the ECG is one of the gold standard ways to diagnose cardiovascular pathologies, or at least heart-related cardiovascular pathologies. Okay. There's some really cool jobs. If you like working, especially with older individuals, there's some really good and really cool jobs where you would basically exercise train people while they're wearing these things. It's called cardiac rehabilitation. It is the standard of care now for people that are post-heart attack. Just about every hospital that is of any size in the US has their own cardiac rehab center. And so you can get jobs and be a cardiac rehab person simply with an undergraduate degree in exercise physiology. Okay. And then there are some master's programs that are going to do things where they're in clinical exercise physiology, where they will train you on how to read all of the pathologies and things that show up here. And those are the kinds of folks that they like to have. They're going to run these cardiac rehab centers. There are outpatient cardiac rehab centers where people go, insurance pays for all of this, because if you will do cardiac rehab, it decreases your chances of having a second heart attack dramatically. And so it's become kind of the standard of care. They're also getting to be a thing if you're interested in nursing at all, where they want a lot of nurses to work in and kind of run cardiac rehab. That seems to be the direction that stuff is going. And so if you have a nursing degree and you're an RN, but you also have some background in exercise phys, then that would also stand you in instead of those things.
It's sometimes like an abnormal EKG cannot be reversed.
Can it be reversed?
Yeah.
It all depends on what it is, but potentially. Sometimes the abnormality shows up because if, let's say I have blockage in coronary arteries, so I have a reduced capacity to bring oxygenated blood to especially the ventricles. Okay? What will happen is you may be here like at rest, and it's not a problem because your heart's not working very hard. It's not beating very fast. It's not beating nearly as forcefully as it can be. So your EKG looks normal at rest, but you still have a blockage. Let's just say. I do a stress test, and I get you on the treadmill, and I evoke the exercise response where your heart rate goes up, where your cardiac output goes up, your stroke volume goes up. The heart contracts more forcefully and more frequently, therefore it needs more oxygen. What happens then is that's when the lack of blood flow becomes an issue, because now the heart needs to make more ATP and it needs all that oxygen and it can't supply it. And so it becomes what we call ischemia. It's lack of oxygen. That lack of oxygen then is going to show up as an impairment in this ability to repolarize and things here. And this what's called S&T segment depression, where rather than here, it kind of does this, okay, and it deflects down. That is due to a blockage. If we put a stent in, or we do bypass surgery, we get rid of that blockage, perfectly fine, perfectly normal, okay, after all of those tests. Other sorts of pathologies, you have a problem in your SA node, and we take out the SA node and we get an artificial pacemaker, sure, we can fix some of those things. You have a problem in your AV node, it's a little dicier. Okay, we have valvular problems. You've got stenosis or stiffening and hardening in the valves. That will show up in certain ways as well. That can potentially be reversed, but also again, it's a little bit trickier. So it just kind of depends upon what the exact pathology is and our ability. We've gotten very good at fixing coronary artery issues and blood flow issues to the heart if we can catch them before they kill you, basically. But some of the other problems that aren't blood vessel related, it becomes trickier because then we have to get into the heart surgically and try to repair things. And nervous system tissue in the heart, like nervous system tissue everywhere. Nervous system tissue doesn't regenerate itself, right? Cardiac muscle is just like skeletal muscle. You get damage to the cardiac muscle. If you can get blood flow back and things, then you can grow some heart muscle back. You can increase the size of it. Like you can take a person that's old and has a smaller heart because they haven't been doing much. You could have them exercise, make the heart work harder. They'll get cardiac hypertrophy just like another person, and that's good. Nervous system tissue stuff in there becomes much more difficult. It just doesn't regenerate. Okay? That may have been way more than you were wanting to know about all of those kinds of things. Right? So I will know on Wednesday. Tomorrow, my mom's having something called an echocardiogram done. They're going to put a Doppler ultrasound on her. They're going to infuse her with that. They're going to watch blood flow through all four chambers. And they're going to watch the perfusion through those coronary arteries. And so she has really high cholesterol. And so they're just doing this as a check to make sure that she has normal coronary function. She doesn't exhibit any of the symptoms during exercise or stress that you'd associate with having a problem, but they're just doing it to check. And so they've done multiple EKGs on her, and her EKGs look fine, but you can then, if you see something here, you can try to confirm it with some other imaging. There's lots of stuff. Okay? All of these things are stuff that either you or people you care about are going to have done to them at some point in their life. Your ability to at least understand what a cardiologist or someone is telling you is going to be really, really helpful. Okay? Because all of you guys are going to be exposed to some of these things. This just shows that. All right. Let's talk about heart rate regulation. So in regular people, your intrinsic rhythmicity is probably going to range somewhere between 60 and 80 beats per minute. There's some genetic components to it that we don't need to talk about or anything else, but most people are going to be somewhere in the neighborhood of 70 beats per minute if we were to basically denervate them and you get no parasympathetic or no sympathetic input. Okay? Intrinsic rhythmicity of the SA node is somewhere around 7. However, if we look at people that are very highly resistance trained, or people that are aerobically trained, or people that are sedentary, their resting heart rate is going to vary very, very much. The better trained you are aerobically, the lower your resting heart rate. Okay? The lower your resting heart rate. So in highly trained endurance athletes, they may have resting heart rates between 30 and 40 beats per minute. Sometimes it may be down into the high 20s. Okay, very low heart rates. We'll get into why that's going to be the case probably on Monday next week. People that are sedentary, it can be much higher. They may sometimes be above 100 beats per minute. Okay. When we exercise, or when you become physically active, or you do anything that requires muscular contractions, heart rate tends to increase in direct proportion to your exercise intensity. So heart rate increases proportionally with energy expenditure in skeletal muscle. Okay? Therefore, we can use heart rate as a pretty easy measure to estimate exercise intensity, which we will do next week. We already talked about this, right? We talked about ways to quantify energy expenditure or ways to try to guess at exercise intensity way back in the first week of class. Okay? The cool thing about heart rate is that when you start doing an activity, it's going to go up very quickly and it should reach a steady state, okay, within about 10 seconds. It should go up immediately. It actually goes up when I tell you to think about doing something, okay? All right? So if I say Why don't you think about standing up and doing squats for us? He's saying that if she has cognition about that, think about performing a squat and make your heart rate go up. Okay. In preparation, the cardiovascular system is like, ooh, get ready, get ready. You might have to do something, even if you don't. But within about 10 seconds, if you're going at some steady energy expenditure, so you're just doing push-ups or just some sit-ups, and you're going to go for 30 seconds. Within about 10 seconds, your heart rate has gone up and it's leveled off. Okay, it's leveled off. All of you have some maximal heart rate. It's primarily determined by age. It's primarily determined by age. The old school easy equation to use is to take 220 and subtract your age from it. So most of you guys are around 19, 20, 21, 22 years old. You guys all probably have age predicted maximal heart rates of about 200 beats per minute. Okay? I am 43, therefore mine will be significantly lower. Okay? Mine would be 177. Okay? So there's a newer equation where you take 206.9 and then you subtract your age multiplied by 2/3, and you get a number that's probably within like 1 or 1.5 beats per minute of the 220 minus age. Again, we're scientists. We're never happier than we're taking something that works perfectly well and trying to parse it down into something that is slightly better, so that we can try to modify something to make ourselves famous. Okay, that's all that we've got. Age predicted max heart rate does not change with your state of training or detraining. Okay, it's very, very stable. And that's going to cause some consequences when we talk about the responses to aerobic training and what changes and what doesn't change. Hard to change max heart rate. Okay. That's what we've got there. Okay. Typically, regulation of heart rate around that intrinsic firing rate is governed by the parasympathetic and the sympathetic nervous system. Okay. And so what we're going to see is that think of it like this. I love this graph, okay? And so you have an intrinsic firing rate, let's just say, of 70 beats per minute, okay? We get you nice and calm. Turn the lights off, put on some waterfall music, have you think calm, soothing thoughts, whatever that's going to be. Then you're going to begin to release acetylcholine from the parasympathetic nervous system. That acetylcholine is primarily going to act on the SA node and the AV node and the atria here because you have receptors for acetylcholine. That is going to hyperpolarize those cells and make it take more input to those cells to get them to reach threshold and generate an action. Consequence of that is a lowering of your heart rate, okay? Lowering of your heart rate. So when you're calm, you're getting input from the vagus nerve or the parasympathetic nervous system that if here is my sort of set point somewhere, as I get parasympathetic input, that's going to fall. So resting heart rate is determined in a lot of instances by the extent to which you're able to apply parasympathetic input to SA. Okay. If you're a person like me that's a little anxious, I don't get as much vagus input on things. So my resting heart rate is going to be a little bit higher. All right. So you've gone from rest, and then we ask you to stand up. Okay. You're going to start doing something. So I go from sitting and I begin to stand up. My heart rate goes up a little bit because of that postural challenge. What's primarily happening is I am withdrawing the parasympathetic input, and I'm beginning to give myself a little bit of sympathetic, a little bit of epinephrine and norepinephrine. Okay? And so what happens then is that sympathetic response is going to function on the AV node, the SA node, and on the ventricles. And it's going to begin as I remove the acetylcholine, as I add the epinephrine, my heart rate's going to go up. Okay, the heart rate's going to go up. That's going to increase my cardiac output. And that may be a good thing at that particular time. As we continue to say, go from standing to walking to jogging, we're eventually going to remove all parasympathetic input and then have only sympathetic input that's going to go up in direct proportion to exercise intensity. And that's going to raise my heart rate. Okay? That's going to raise my heart rate. So for instance, for our test on Wednesday, some of you are going to be anxious. Right? You're going to get a stress response. Your heart rate will be higher. Okay? It has some blood pressure responses, which is why you have to pee when you're anxious. Lunch. Okay? That's how this is going to be regulated. It's a combination of sort of the net balance of the net input of the vagus nerve and the sympathetic nervous system. I say primarily. Okay? That's how we regulate the heart rate. Okay. So let's talk about another parameter or another variable of interest that tells us something about the function of your heart. And that's called stroke volume. Okay, stroke volume. Stroke volume is the amount of blood that is ejected from the heart during one heartbeat. Okay, the amount of blood ejected in one heartbeat. Does anybody have, and I forgot to bring mine from my office, does anybody have like a little thing of like hand sanitizer or a little thing of lotion or something in your bag that I could borrow? Yes. Thank you, thank you, thank you. Okay. Now, this contains 28 milliliters. Okay, 28 milliliters. It's about 1 ounce. Okay, 28 milliliters. Every time an average person, none of you guys are average, but the average amount of blood that is ejected from the heart during one heartbeat is going to be somewhere between 2 to 3 times as much as this. Okay? Every time your heart beats. So this is about 30 milliliters. Average stroke volume is about 80 milliliters at rest. Okay. Some of you are going to be under that 80. Some of you guys are going to be over. Stroke volume and the amount that comes out is primarily controlled by the size of your left ventricle. The size of the left ventricle. The left ventricle is bigger than the bottle that the blood can go into in the left ventricle. The bottle is bigger. So it then can hold more, so you can then eject more every time that's going. Okay. Good. Appreciate it. Okay. That's what we've got. Calculating stroke volume. Okay, if you read in any kind of textbook, it's going to talk about stroke volume is the difference between end diastolic volume and end systolic volume. Some very, very simple math. End diastolic volume is very simply the amount of blood in the left ventricle right at the beginning of ventricular systole, or right at the end of atrial diastole. Okay? So right before the left ventricle begins to contract, how much blood is in it? That's called end diastolic volume. Just filled it up. End systolic volume is the converse. How much blood is left in the left ventricle? Still in there after it's contracted. Okay? So you relax it, it fills up, then you squeeze it and some comes out. Most of the time, when the left ventricle contracts, or realistically when any of the heart chambers contract, we're not going to push out all of the blood that is in it. Okay? Contraction tends to not be forceful enough most of the time to force all of the blood out. There's going to be a little bit that's left in. So if we know how much there was at the start, we know how much there was at the end, the difference between those two things is what left during the contraction. So Stroke volume is in diastolic volume minus in systolic volume. Okay. All right. Another parameter that you need to be aware of, because it's going to tell us a lot about cardiac function, is something called ejection fraction. Right? Ejection fraction is the ratio of in systolic volume to in diastolic volume. So it's basically, right, the percentage of in diastolic volume that is pumped out. Okay. I call this stroke volume over in diastolic volume. That's ejection fraction. Okay. At rest with good cardiac function, most of you guys are going to eject about 2/3 of the blood in the left ventricle. As we increase exercise intensity, as the heart has to work harder, ejection fraction should go up. In people that have some kinds of cardiovascular disease, their ejection fraction may be very, very low. That can be indicative of improper function or damage to the left ventricle. If their ejection fraction falls. If it falls far enough, you're not able to move enough blood around, and that can cause all kinds of problems in other tissues. That's stroke volume. All of the parameters that we can compare among people that are roughly the same age. Stroke volume is arguably the thing that is the best predictor of who wins an endurance race. What it really should be is your stroke volume, your max stroke volume, expressed relative to your body weight would be the best way to do it. You're all about the same age. So your max heart rates are all about the same. Whichever of you per your body size has the largest stroke volume, and I know who I'm betting on, probably is going to have the highest VO2 max and is therefore probably going to be the best endurance. We'll talk about why that happens. Okay, next week. Stroke volume is really, really, really. Okay. The product of stroke volume and heart rate is something called cardiac output. Cardiac output is abbreviated as Q. Please don't ask me why. I have no idea. But Q is equal to heart rate multiplied by stroke volume. So the number of beats, number of times the heart contracts per minute, multiplied by the number of milliliters of blood that are ejected per beat. And we tend to get a number that's big enough to express that as liters of blood that are pumped out of the heart per minute of time. Okay? So generally, cardiac output is normally about 5 to 6 liters of blood per minute. Okay? Most of you guys, we don't really do much with this in class, but most of you guys have a blood volume of between 4 and 6 liters of blood that's in your body. Your resting cardiac output is going to be pretty similar to what your blood volume is. You're going to move all the blood in your body through your heart once every minute. Okay? During exercise, or times when we make heart rate and stroke volume go up, that's going to make cardiac output go up. Cardiac output may go up 4 or 5 times. So you're going to take this 5 liters per minute at rest, and you may be able to get to 20 liters per minute of blood that is leaving the heart per minute during high rates of exercise. In people that are elite athletes, because their stroke volume is so big, they may have resting cardiac outputs that are like 8 liters per minute. And so they can increase theirs 4 or 5, 4.5 times. They may move it up to like 35 liters per minute cardiac output. Okay. Your cardiac output. Okay. The cardiac output is one of the things that determines your VO2 max. Whoever has the largest cardiac output is going to have the largest VO2 max, which is our measure of cardiorespiratory endurance, cardiorespiratory fitness. Therefore, in people that are all about the same age, you all have about the same max heart rate. So the thing that causes the difference in your cardiac output is your stroke volume. Right? That's what stroke volume is. So, okay, we're going to stop here for today. I'll be happy to field some more test questions prep in the next, say, 10 minutes or 15 minutes if you guys want. Otherwise, lab is due Friday. Test will be on Wednesday. Okay?